This special edition episode of the Mod Pod has been developed and sponsored by Genetics and Eyecare Today.
Hello, listeners. Welcome to this podcast mini-series entitled Genetics and Eyecare Today. I'm Dr. John Gelles, and with me today is Dr. Liz Yeu.
Hi.
So, I'm an optometrist at the Cornea Laser Eye Institute and the CLEI Center for Keratoconus in Teaneck, New Jersey, where I'm the director of specialty contact lenses. And I'm also a clinical assistant professor at Rutgers, New Jersey Medical School in the Department of Ophthalmology.
And I am an anterior segment surgeon and partner at Virginia Eye Consultants in the Eastern Shores of Virginia. I'm also an assistant professor of ophthalmology at the Eastern Virginia Medical School.
This series will guide listeners through discussions about the evolving world of genetic testing in eye care, and will review how innovations in genetic testing have affected screening, diagnosis, and the care of patients with corneal dystrophies and keratoconus.
Be sure to go back earlier in your feed and listen to the first episode of this series. And if you're listening on a podcast app, subscribe to the series to get our short monthly episodes.
You'll also want to check out the Genetics and Eye Care Today website for articles and other resources that explore these exciting developments. We'll link this site in the show notes. Now that that's all out of the way, let's go ahead and jump in.
All right. So, Dr. Gillis, I wanted to ask you about how you are monitoring patients with keratoconus. So, when you have different regimens and treatments with keratoconus, you recognize obviously that this can be a more personalized process using the risk score data from an AvaGen genetic eye test. John, I'm curious, as someone who closely monitors these patients, how does a genetic profile affect your decisions to observe versus refer or change your treatment plans with regards to such patients with keratoconus?
That's a great question, Liz. Generally, genetic testing really adds a new layer and more actionable data to my diagnostic data set. When we look at these data sets, obviously they're including the clinical observations. So, what are we seeing on the various different scans that we're doing? In our office, we're using not only corneal topography, but corneal tomography, some biomechanics, and aberrometry. But then there's also, the demographics sort of stuff. So, what's their background? Do they have a history of atopy? Do they have connective tissue disorders? Anything that would be, correlated with keratoconus. But those are generally not the demographics and lifestyle sort of things are not generally actionable on their own. Now we have genetics to add to this as well. So as we start to get, all these pieces, the corneal curvature or shape, the biomechanics, the objective vision, and now adding genetics to this, we really get a complete picture of the individual.
Sure. So tell us a little bit more about how this genetic data can personalize keratoconus patient management.
So like let's think about patients who have, generally low risk, based on their clinical observations and their demographic factors, right? So let's say, the anatomy is somewhat borderline or slightly questionable. We're talking about like minor irregularities in the front surface of the cornea. There might be some slight, refractive change or anatomical change that may happen with these eyes, where you're going, that really isn't enough to do too much for this individual. Or, anatomy looks totally normal, but they have a positive family history. Before we have, the AvaGen test, this perceived low risk, we may have said, well, these individuals are not a real high risk factor. I'll see them every, 6 to 12 months. And, in some practices, that interval may be even longer, maybe 12 months. But in the era of genetic testing where risk is much more certain, I can know early and personalize the management to that individual. So, when I have a patient who has had the AvaGen test and is identified with high risk, my follow-up interval definitely changes in those individuals. Instead of saying, hey, we're going to see every 6 to 12 months, somebody who's been identified with a genetic profile for high risk, I'm going to say this individual needs to come in every 3 months. And then those changes that I may have thought were, insignificant are now something that's much, much more actionable.
And with this information, when you are seeing them from every 3 months to 6 and 12 months, what is an absolute must have in a diagnostics as you are seeing these patients in follow up?
So generally, when I'm looking at these individuals, I'm looking at changes to their corneal topography and tomography. So we're looking at changes to the symmetry to the front surface of the cornea, specifically, kind of what was outlined in the Rabinowitz papers, so long ago about IS ratio. So, the comparison of the top to the bottom of the cornea, is that getting, more asymmetric with time? Are we starting to see more axis skewing? Are we seeing more steepening of the anterior curvature? If we go to the elevations, we're really looking for, are we having more of an elevation change on the front or the posterior surface of the cornea? And, changes to corneal thickness, not just the thinnest point, but also the change of that corneal thickness as we go out towards the periphery of the cornea. And, even breaking down thickness even further to epithelial thicknesses and looking at thinning over the apex, kind of thickening around the base. So when we look at all these sorts of changes in metrics over time, those are the sorts of things that we're really looking at. But if we put all of those in the context of having a high risk score, now all those little micro changes that may happen on the area, I'm now much more concerned for that individual about change than somebody that I didn't know that and I perceive them as being low risk.
And how does a patient with that high genetic risk score affect your actual referral pattern?
Well, I'm definitely much more likely to refer a patient for treatment if they have a high risk score, but only mild signs of keratoconus on clinical evaluation. So, in many of these individuals where like a slight change in their corneal topography may have been actionable in the way that I'm going to see them for more frequent follow up, or more of a, wait and see, those individuals, their changes are now significantly more important, and those small changes become a refer and treat rather than a wait and see. Because, as we all know, corneal collagen cross-linking works, and early treatment with it is going to save vision. So having this test really, really significantly changes the way that you're going to practice and the actionable, or rather the actions that you're going to take for these individuals.
So, John, I've even noticed that in my patients who may be mild or moderate, based on what I'm seeing with their topography and maybe their high astigmatism, but then, I find out that their actual habits or their medical history also includes eye rubbing and allergic conjunctivitis. So now this elevates my concerns about them being a moderate suspect. And then I'm thinking, I really want to get that AvaGen risk score, and then see an allergy specialist. What do you think about that kind of paradigm of me starting with the clinical picture and then moving forth that way?
I think it's a really interesting question, Liz, and I think what we're gonna see as we get more and more comfortable with genetics in general in the eye care space is that as time goes on, we might think of risk scoring from genetics like the AvaGen test as the first piece of data that we should consider getting rather than the last piece of data, right? Because if we put everything into the context of the overall objective risk of this patient based on their genes, then we take those clinical factors, and those marginal clinical findings now become way more important to the overall picture, right? So, like, if we think of somebody who, clinically we may have said, yeah, they're like a 45 diopter, with 2.5 diopters of oblique astigmatism and like a 1.4 diopter IS, we're kind of looking at that and going, that's kind of very mild, maybe a form frust sort of case. But if we put that into the context of this individual has a really high genetic risk score, and we're seeing those sorts of changes, that individual I'm now watching much, much more closely than I would have otherwise.
That's a great point that you make, that instead of using the AvaGen as per se a tiebreaker in these borderline patients, if I had the advantage of seeing the AvaGen risk score initially, I wouldn't need, more than one maybe suspicious area for me to say we're not going to consider refractive surgery, or we need to watch more closely, or we need to encourage the patient and recommend earlier treatment. So I really like that perspective of how you just mentioned that. So, in our previous episode, we reviewed the polygenic aspects of AvaGen, the genetic eye test. But what about the monogenic aspects of the test? Dr. Nazneen Aziz explains more.
When a patient undergoes evaluation with the AvaGen genetic test, they are screened for two pathologies at the same time: keratoconus, which is a polygenic disease, and corneal dystrophy, which is monogenic. Monogenic diseases usually occur due to a single gene defect in a patient's genome. For corneal dystrophies, one of the genes we test is TGF beta I. Because TGF beta I induced corneal dystrophies are determined by the presence or absence of a defective gene, lifestyle changes do not influence whether the disease will occur or progress if a person possesses the defective gene. Therefore, the mere presence or absence of the aberrant gene in question makes this genetic test easy to interpret, as the result is a binary yes or no. But the AvaGen genetic test does not stop at simply determining whether or not a patient's genotype will lead to corneal dystrophy. Instead, the test results determine which gene variant a patient has, allowing the doctors to subtype their disease. There are more than 70 variants of the TGF beta I gene that are linked with corneal dystrophies. Depending on the variants detected in the gene through the AvaGen eye test, a patient present with any of the 8 known phenotypes of corneal dystrophy. Different subtypes of corneal dystrophy present at different ages and with different patterns of progression. In some cases, a clinician can determine that the patient has some type of corneal dystrophy, but clinical observations or imaging results may not point to any one specific subtype. In these instances, the doctor who has the AvaGen test in their toolkit can confirm their clinical observations with a definitive diagnosis. The addition of genetic data to clinical observations in these patients can lead to earlier, more accurate diagnosis and a treatment plan personalized to their patient. For Genetics and Eye Care Today, I'm Dr. Nazneen Aziz.
In this segment, we want to discuss how a refractive surgeon would use genetic data to help guide treatment decisions. Liz, let's imagine a patient in their 20s or 30s comes into your practice for a LASIK consultation. And based on the evaluation, you can see they have a suspicious looking cornea. So, can you describe, what might make it suspicious and what you might do?
First of all, the younger the patient, the more heightened my level of suspicion is going to be with any irregular finding or abnormality that I see. So, a patient who's coming in their 40s with a little bit of asymmetric bow tie on topography, I'm going to be a little less concerned than someone who's either 18 to 25 years of age, because as we know, the cornea naturally cross links over time. So, a younger patient, I definitely am on a more heightened alert. I do want to, see that there's symmetry, of course, but any patient who has like a borderline steepness, like greater than 45 diopters, or a higher level of astigmatism, irregularity of their astigmatism, or like truncated, very central bow ties, these are patients that I would likely run the AvaGen genetic eye test. If the test showed a moderate or higher risk score for keratoconus, I definitely would say, because of what I'm seeing on their inherent data from their specific AvaGen genetic eye test, plus what I'm seeing objectively with the steepening or the irregularity on the topography, it's enough of a warning for me to say that the strength of the cornea is of concern to me, and I would not perform a corneal based refractive surgery on this patient. Now, this does open up the opportunity of, one, let's wait and see what happens over time. Or two, if this patient does fit the parameters for ICL surgery, that is always on the table.
Nice, nice. I think that the Avogen test just offers so much in the way of kind of determining that. Like, are you going lens based? Are you going corneal based? And kind of, figuring out which direction, you might go or might determine to just not do anything. When you look at these patients, let's go back to that one. How would you treat that 20 to 30 something?
John, you bring up such an amazing point, because now this patient I have deemed to be a person at risk. I certainly wouldn't consider doing refractive surgery on them. Depending on how high or suspicious my concern was, would dictate when I would want them to come back. But the reason for their return is so that I can look at interval imaging, see what the difference maps look like, see if their refraction changes either with respect to myopia or the astigmatism level. Why? Because that younger patient may absolutely require or should be considering collagen cross linking, because we have to remember, if this is caught early and we initiate therapy quickly enough, these patients can be true success stories. And now the patient has returned to you with significant change in their prescription, which you can discuss with them, and the findings that you are seeing. And we know that this will help to at least to stiffen the cornea, which will stabilize their shape and their disease progress, will also hopefully stabilize, especially because they are the best group of corneas that do stabilize with cross linking as compared to older patients. And this is how I would approach a patient where I'm getting that higher risk score from AvaGen plus suspicious findings objectively with the patient.
So Liz, if we kind of switch gears now, and let's imagine a patient comes in with those kind of borderline findings, and you have that Avogen test, prior to they want refractive surgery. How are you going to proceed with those individuals now that you have that data from the Avogen test?
I would look at the actual risk score analysis on the AvaGen test to kind of guide me. So, obviously, if I was suspicious enough in order to order the AvaGen test on my refractive evaluation, then I'm already thinking that ICL is an option. And ICL can likely be an option regardless of that risk score analysis. But if it's a patient who is a high risk, right, for keratoconus, then I certainly am not going to consider any corneal refractive surgery. But if they're like a mild, maybe mild, low, moderate risk of keratoconus overall, and then they're coupled with a little bit of slight asymmetry, or maybe it was just some against the rule astigmatism, but their other parameters looked good. For example, a nice thickness to their cornea. Um, for that patient, certainly we could consider something like collagen cross linking plus PRK staged. But again, I do think this is where utilizing the AvaGen test can help my decision making process because, of all the different refractive surgery options, considering them, it's still, I want to be able to make that firm recommendation. And for me, part of being able to make that firm and healthy recommendation for the patient, the more knowledge I have, the better armed I am to feel confident with that decision that I'm proceeding with.
Liz, that's a great point. The use of this test in the stratification and trying to determine, what sort of a procedure might be most appropriate for an individual. Like, a normal cornea, low risk, that individual is definitely a go for LASIK versus, somebody who's normal but has a much higher risk. That individual might be a better candidate for ICL. Or if you have somebody who's got a slight irregularity and a low risk of PRK, or like a PRK plus cross linking, and somebody who's high risk plus irregularity, they're not treating them at all, or doing cross linking, or then reverting to a lens based procedure. um, you know all it's just so interesting to see how this test can really guide, or help to guide decision making in surgery.
Well, thanks for joining us on this second episode of Genetics and Eye Care Today. To stay up to date, subscribe in your podcast app of choice, and you can look out for the next episode to drop in your podcast feed. Next month, we'll discuss how genetic data can support early corneal cross-linking decisions. For now, I'm Liz Yeu,
And I'm John Gelles.
asking you to join us next time on Genetics and Eye Care Today.